Good afternoon, everyone. Let's get started. So, in the last session, we have covered the complete anesthesia chapter, and I have shared few questions with you. So, did you get a chance to attempt those questions? Does anyone attempted those questions? Anyone have any question?
Yes,
Any
ma'am.
doubts? Okay, tell me the question number. Let me open the assignment too, so that we can review that assignment together. Okay. So, what was your question number? Jamil, I think you asked the question, right?
Yes, ma'am.
Tell me the question number.
Uh,
Except Jamil, does anyone have any other question from this assignment? Are you guys able to solve this assignment? Okay, let's do one practice question together. If we were able to clear that question, then we will move further. Otherwise, we will repeat the same thing which we did in the last session. So let's try to solve the question number.
Hello, ma'am.
Yes, Jamil.
Ma'am, question number 12, ma'am.
Question number 12.
Yes, ma'am.
Okay, let's do that together.
Uh, yes, ma'am.
Yes.
Yeah, this one, ma'am.
Okay, so what's your doubt in here?
Ma'am, here I'm not getting this. Like,
Okay. So in our question, patient is having a knee replacement surgery, and our surgeon requests that in addition to the anesthesia, we have to give the lumbar epidural post-operative pain management so that even after the surgery, patient is able to tolerate the pain after the procedure. So our surgeon is providing the anesthesia as well as lumbar epidural so that we can infuse the epidural pain management medicines. So we did anesthesia as well as the post-operative management for 2 post-operative days. Now,
yes, ma'am. That last line, ma'am. The anesthesiologist performed post-operative management for two post. That one.
operate, yes. So we did the post-operative management for 2 consecutive days. Let's say patient had a surgery on the April 1st and we did the post-operative management for the April 1st as well as on April 2nd. So we did the post-operative management for 2 consecutive days. That means we have to bill that for 2 days. Now let's take, so the first one is 00140, 14200. So we have to rule out the options from 01400 and 01402. So let's see what is the difference between these two. So 01400. 014. So 01400 is for the open and surgical arthroscopy procedure on the knee joint, but our patient is coming for the knee replacement. Knee replacement surgery is also known as arthroplasty. So we have to bill arthroplasty. We have a specific code for the total knee arthroplasty. So we have to rule out the option number A and option number D. Now we are left with option number B and option number C. The difference between these two, the code 62326. Now let's go and find out what code 62326 says. We can do one more thing here. We can refer 019996 code to see if there is any guideline. So 01996. Here we have a 01996. That is for daily hospital management of epidural or subarachnoid continuous drug administration. And we have to build this code on a daily basis. That means if our doctor is doing for 2 days, we have to use 2 units for that. And in our option C and B, in both the options, we have the unit 2 here. So these two options seems correct. Now let's see what this 62326. So to pull the code, we have to refer 62326. Here we have a 62326. This procedure we need to build when we are going to insert the catheter or lumbar epidural catheter. So you can see here, when we are adding the epidural or subarachnoid lumbar catheter, then we have to build the 62326. This will represent that we have inserted the catheter for the continuous infusion. So in our case, we did the anesthesia, we inserted the epidural catheter, and with the epidural catheter, we provided the continuous infusion for 2 days. That means we have to bill continuous administration for 2 times, as we did that for 2 days, and we inserted the catheter only once. That means we have to bill this 62326. Example 62326 will just represent that our doctor inserted the lumbar catheter to infuse the medicines. Clear?
Yes, ma'am. Yes, ma'am.
Any other questions, Amil? Okay, now tell me one thing. Why we have this AA modifier here? What is the meaning of this AA modifier? Why we need the AA modifier? What AA modifier will represent? Anyone? What is the requirement of AA modifier? I'm going to highlight the modifiers which I have shared over the group last week. Just read that picture and tell me what is the logic of AA modifier. Refer the picture and tell me why we have used AA modifier here. Any
Ma'am,
answer?
hello,
Mm-hmm.
ma'am. Ma'am, if the anesthesia is done by anesthesiologist, then we can use that.
Exactly. When the service is performed by the anesthesiologist, then we have to use the AA modifier to represent that this services is performed by the anesthesiologist. If it is done by a CRNA or surgeon, then we have to use a different modifier to represent who did this services. Now we have to go for question number 4. So, what's the question number 4? Just a second. Deshmukh, what is your question here? Vaishnavi, what is your question at the question number 4? What's your doubt? Vaishnavi, you asked the question number 4, right? What's your doubt? Oh, send a message. Just a second. How it's 01382 coded. Okay. Now, in our case, the anesthesiologist perform MAC. You have to remember one thing. Whenever our doctor is providing the MAC, we have to utilize a QS modifier to represent that monitored anesthesia care has been given to the patient. Now, patient is undergoing the arthroscopy of right knee. Arthroscopy is this is not the open procedure. Doctor create few portals in the knee and then inserted the camera and did some surgeries, or just a diagnostic surgery, because we does not have any documentation that doctor is going to do any procedure here. We have just two options here, 01382 and 01400. Now let's refer this quote. Let's try to open it. 108. It's 0. So 01384 for diagnostic arthroscopy procedures and 01404 for surgical open and surgical arthroscopy procedures. Now, the difference between surgical arthroscopy procedure and the diagnostic arthroscopy procedure is when there is an intent of any chiropodic procedure, then we are going to use the 01400 and we are going to call it as a surgical arthroscopy. Let's say if doctor want to repair the labrum of the knees with the arthroscope, then we are going to consider it as a surgical. But if our doctor is just doing the diagnostic arthroscopy there, doctor is just reviewing the, exploring the knee only. He is not doing any debridement, he is not doing any labrum repair, he is not doing any other procedure there. Meniscectomy, nothing is going to be happen there. Then we are going to use 01382 and 01400 we have to use when there is a procedure. Clear, Vaishnavi?
Yes, ma'am.
Now you have to tell me why we have used, so what should be the answer? A or B? Just refer the question and tell me the answer. We have already ruled out option number C and D. Now you have to tell me the answer. What will be the answer? A or B?
B, ma'am, B.
B, ma'am.
Yes, because based on our documentation, MAC has been performed. So we have to append the QS modifier. Perfect. Now we will do one question together and then we will move further. Okay. Yes, right. Try to attempt this question in a 2 minutes. It's 3:18. We will wait till 3:20 and then we will discuss. 1 minute left, and I just received one answer. Okay. Okay, I have just received the answer from the Vaishnavi, Zamir, and Prerna. So they have answer 040 C, A, C, and D. Okay. Okay, now let's do this question together. So in our question, patient developed the infection on her front chest. The decision is to make the debridement. So doctor did the debridement of the infected tissue to advance her recovery. The patient is taken to the OR suite where the infection has been debrided. The debridement involves skin and subcutaneous tissue till the level of fascia, and doctor did the anesthesia and monitored the patient during the surgery. Now, our doctor just did the debridement till the level of fascia, and we have provided the anesthesia for the debridement on the front chest. Now, let's see the difference between these codes. 400 integumentary system. Integumentary system is, what is integumentary system? What all organ comes under the integumentary systems? Any procedure performed on skin, subcutaneous tissue are known as integumentary system. So in the integumentary system, we cover dermis, epidermis, hypodermis, that is also known as subcutaneous tissues. So in our case, doctor is just doing the debridement on the integumentary system, on the interior trunk. So that was on the chest, so that is anterior trunk. Someone answered with the option C, I think, right? C is 560. Why we cannot use 00560? Because that procedure is not on the heart, not on the pericardial sac and the great vessels of the chest. If the procedure is performing on the heart, that organ, then we are going to use the 00560. We cannot use 00540 also, that because doctor did not do any thoracotomy procedure. Thoracotomy means creating an incision on thoracic cavity. That is thoracotomy. Then we have 00520. 00520. That is closed chest procedure. Closed chest procedure means if there is any procedure where we doctor need to do any procedure on the chest, and for that we are providing the anesthesia, then we have to use 00520. Closed chest procedure include bronchoscopy, laryngoscopy, and thoracoscopy. These are the closed chest procedure. The doctor is doing the procedures on the chest, but doctor does not need to do any invasive surgeries. Doctor does not need to do any cut or any incision there. So our correct answer should be 00400 because the procedure is on the skin and subcutaneous level. Answer A. Zamil, is it clear to you that why we are going to pick A instead of the C?
Mm.
Zamil, clear hai? Or do I have to repeat one more time?
No, no, ma'am.
Clear, right?
Yes, ma'am.
Okay, so whenever you are going to build the procedure or the anesthesia, you have to see where the procedure actually is happening. On the basis of that, you are going to pick the code. So now, as we have completed the anesthesia part, now let's start with the new chapter. So now we are going to start with the surgery. Our surgery code starts from 1 series till 6 series. 100 to 699 codes are divided based on the body system or the depth of the surgery. Like the code from series 1 will represent the surgeries performed on the integumentary system. The 2 series will represent the surgeries performed on the musculoskeletal, 3 cardiorespiratory, 4 gastro, and 5th genitourinary, and so on. So today we are going to start with the 1 series and we will review few surgical guidelines. So before proceeding with the surgical guidelines, I have one question for you all. What is a surgical package? We have already discussed this while we are discussing the modify 55, 56, and 57. So now tell me, what is the surgical package? What is a global period surgical package? Okay, let's rediscuss this. Whenever we are going to bill a particular surgery, that surgery include a surgical package. Surgical package. Surgical package always include pre-operative visits, post-operative visits, and surgery. So whenever we are going to bill a surgery, that surgery always include pre-operative visits. Pre-operative means any evaluation and management done by the provider at the day of surgery or a day prior to the surgery. A day prior to the surgery. Prior to the surgery. So all preoperative visits are included in the surgical package. That means that when we are going to bill the surgery, that previous evaluation and management services are always going to come or cover under the surgery. This statement is clear to everyone or any doubt? Any questions? Okay, I'm going to repeat it one more time. Now we will do with one example. Let's take an example for RCT, root canal treatment. Whenever we are going to a dentist for a root canal treatment, dentist is going to ask for a particular package amount and he will say that this much visits are included in the root canal treatment. So whenever doctor is going to do that surgery, that procedure, that root canal procedure, that pre-operative visit, doctor needs to evaluate the patient before the surgery, before the procedure. He needs to evaluate the vitals of the patient and see how the patient is performing. Is the patient is correct for the surgery or not? So that pre-operative visits are included in the surgery and we are not going to bill that separately because that is included in the surgical package. Does that make sense? Guys, are you guys able to understand what is the pre-operative package or not? I need the answer. Vaishnavi, Zamil, Prerna, are you guys able to understand what is pre-operative or not? You are not able to understand? So whenever we are going to build a surgical package, that pre-operative visits where the doctor needs to review the vitals of the patient, that surgery and the post-operative visits are always included in the surgical package. So pre-operative visits and the post-operative visits are not separately payable, not separately payable with the surgical package. So anything happened during the procedure or after before the procedure, any evaluation that is included in the surgery, so we are not going to bill it separately. Local anesthesias included in the surgery, we are not going to bill that separately. Local and topical anesthesias also, we are going to bill the general anesthesia as well as the regional anesthesia, but we are not going to bill the local anesthesia as well as the digital anesthesia, oh sorry, topical anesthesia. Any post-operative visits during the global period, there are few surgeries where we have the 10 days global period, there are few surgeries where we have the 90 days global period, and there are few surgery where we have a 0 day global period. Let's say patient is coming for the herniorrhaphy, so herniorrhaphy does not have any global period, so any post-operative visit after the surgery we are going to bill that. Any minor surgery such as exploration of the neck, exploration of the any stab wound, that will be 10 days global period. And any major surgery, let's say CABG, and any other major surgery, that will be 90 days global period. 90 days global period means that you are not going to bill any separate evaluation and management visit during that global period. So that means evaluating the patient in the post anesthesia recovery area or during the post operative period, that is included, and we are not going to bill that separate. Now let's start with the surgery section. We will start with the integumentary section first. So integumentary section includes any procedure performed on epidermis, dermis, and subcutaneous tissue, as well as on the nails. We are able to find the codes for the procedure performed on the nails also. So in this chapter, we will learn any procedure or codes for any procedure performed on the skin, external skin, dermis, and the subcutaneous tissue, as well as the on nails. Okay. So in this section, first section we have general. In the general section, we have a normal code which is not based on the anatomical location, that is based on the lesions. So that will be comes under the general section. In the general section, we have a first section, fine needle aspiration, FNA procedures. Fine needle aspiration procedures kind of a biopsy procedure. These are a kind of a biopsy procedure where doctor needs to collect the fluid sample or the tissue sample from the cyst or mass, or from whenever doctor wants to remove that, take that sample. So the difference between fine needle aspiration as well as core needle aspirations, we have a two types of biopsy techniques with the needle, fine needle and the core needle. So in the fine needle, we have a very fine needles, and then the core needle, we have a little bit thick needles. Let's see the difference here. FNA versus core needle biopsy. So I'm going to open the image. So you can see here in the fine needle aspiration, we have a liquid sample tissues, sample of the fluid or sample of the tissue from the cyst or mass. Whereas in the core needle, we have a sample type like complete tissue type. So in this core needle, we have to use a little bit thick needle compared to the fine needle. But in the fine needle aspiration, we have to use fine needle. So the difference in the coding, when we are going to aspirate with a fine needle, then we have to use a code from series 100212 to 10012 in all the situation, whether it is on the kidney, whether it is on the skin, whether it is on the liver. Whenever doctor is doing any FNA biopsy, FNA biopsy means any biopsy with the fine needle aspiration, then we are going to use a code from series 100212 to 10012. But whenever doctor is doing any core needle biopsy, so core needle biopsy codes varies based on the depth of the procedure. So let's say if the doctor is picking the or taking the sample from the kidney with the core needle biopsy, in that case you have to use a code from series 5 from the genitourinary series because kidney is a part of the urinary system. In the same way, if the doctor is doing any core needle biopsy from the intestine, in that case you are going to use the code from series 4. But whenever, if the doctor is doing any FNA biopsy, any FNA removal, in that case, we have to use one series code in all the situation. Does that make sense? Does anyone have any question till now? Guys, you guys are able to understand? Yes or not?
Yes, ma'am.
Okay, Zamil, clear the difference between the fine needle aspiration and the core needle biopsy and why we have
Yes,
to see the difference?
yes, ma'am. Yes.
Okay, now let's see the codes we have here. So our first code is 10021. Our FNA codes are vary based on the imaging guidance or imaging modality used for the FNA. So are all codes divided based on the imaging modality as well as imaging guidance and lesions where the doctor did the FNA. So our first code is without imaging guidance. So if it is a first lesion, we are going to use a code 10021. For each additional lesion, we are going to use a separate unit of 1004. So let's say if the doctor did the FNA of the 4 lesions, so without imaging guidance, then what we are going to do? We are going to use 10021 plus 1004 into 3 because our first lesion covered under the 10021. For rest 3 lesions, we are going to use 1004 into 3. Now let's take another situation. So as I already told you that our all codes vary based on the imaging guidance. So we have a code for the ultrasound guidance. We have a code for the fluoroscopy guidance. We have a code for the CT guidance and the MRI guidance. And for all situation, we have a each additional code also. That each additional lesion, if the doctor is doing the FNA for each additional lesion. So whenever doctor is doing any procedure with the imaging guidance as well as without imaging guidance, then we are going to use a separate code for each imaging modality. So that your code is based on the imaging guidance as well as lesions. So if doctor use the different modalities or the different imaging guidance, you are going to use a different primary code based on the lesion, and you are going to use the modifier 59 to represent that these are the separate lesions. So modifier 59 will represent that these are the distinct procedures. That these are the distinct procedure and happening on the different lesions. So again, if the FNA biopsy is performed on one lesion and the core needle biopsy performed on a separate lesion, same session we are going to build both because the both are the different one, and we are going to use a 59 modifier to represent that these are the different lesions. And if at the same time more than one FNA biopsy is performed on the separate lesions, but at the same session, same day, with the different imaging modalities, we are going to use two different primary codes and we are going to use the 59 for each additional imaging modality. Now let's take an example. Let's say doctor removed 5 lesions. Doctor did the FNA for 5 lesions. So the first 2 lesions are done under the ultrasound guidance and rest 3 are done under the fluoroscopy guidance. Now what we are going to do? To represent the first two, we are going to use 10005 plus 10006 because there are 2 lesions. So first lesion we are going to represent with the 10005 and each additional lesion we are going to represent with the 10006. And then 3 lesions were removed with the fluoroscopy guidance. So for first lesion we are going to use 10007 and for rest 2 lesions which has been done under the fluoroscopy guidance, we are going to use add-on code 100008. So this will represent that 3 lesions has been removed under the FNA. Any questions in the FNA? Any questions, any doubt? Okay, I'm considering that none of you have any question. Now I'm going to mention any particular question here. And let's say 2 lesions were removed under the without guidance. 2 lesions send me the answer for these questions. It's 3:44. Let's wait till 3:46. Then we will discuss together. 1 minute left. Shilpa, we are going to use just one code here, even though 5 lesions has been removed. So total 5 lesions has been removed. You used one code only.
Ma'am, for the second one, 1005 it will be.
Okay, tell me the complete answer.
One will for second lesions will be 10021,
Okay,
and the second what third lesion it will be 10005.
okay. Let's see who else responded on the question. So I got the answer from the Zamir. Okay. Vaishnavi, any answer from your end? Now we have to remember one thing, that our code is based on the lesion, that the number of lesion will determine the number of codes as well as the number of modalities, imaging modalities. So the first two lesions were removed without guidance. So the first lesion we are going to represent with the 10021. This one is for only first lesion. This one is for first lesion only without imaging guidance. And for additional lesion, we are going to use 10004. That will represent that additional lesion has been removed without guidance. Now, for rest 3 lesions, we are going to use that we are going to bill under the ultrasound guidance. So for ultrasound guidance, our first code should be 10005. 10005. And we are going to use the modify 59 also to represent that this and this are the two distinct, performed on the two distinct areas. So modify 59 will represent distinct procedures. Distinct procedure. And then we have 0006, 10006. That will be for each additional lesion. Each additional lesion. That means our first lesion was covered under the 10005, and then we are going to lift with code 2 rest lesions. So the complete answer should be this one. Clear that why and how we have used this much of codes? Shilpa, is it clear to you now?
Ma'am, can you explain once again? It's been confused.
Yes, definitely. So our code are based on the lesions, that how many lesions has been removed, as well as based on the guidance, that under which guidance it has been removed. So now in our case, total number of 5 lesions were removed. So the first 2 lesions we are going to bill, the first 2 lesions were removed without guidance. It is without guidance. Let me rub everything from here. Just a second, huh? So 10021 will represent the first lesion without imaging guidance. So 10021 will just going to represent the first lesion. We have to bill for each lesion. Okay. So it is first lesion, and any additional lesion we are going to bill that with the 10004. So for first two we are going to use 10021 plus 1004. 21 will represent the first lesion and 0004 will represent the each additional lesion after the first one. Each additional lesion after the first one. Then we have 10005 and 10006. We have used this 10005 and 10006 for the ultrasound guidance. So for ultrasound guidance, we have first lesion 0005 and we are left with two extra additional lesion. So we are going to use this CPT two times. Clear?
Yes, ma'am.
Okay. Zamil, is it clear to you also?
Ma'am, here three lesions are removed, ma'am. So it will be 10006 into 3.
No, it should be 10005 plus 10006 into 3. For first lesion, we are going to use the primary code first, and for each additional lesion, we are going to use the add-on code. Okay, remember, for each additional imaging modality, we are going to use the particular primary code. Like it's for ultrasound guidance, we have this primary code. We are going to use this first, and for extra units, we are going to use 10006. Clear?
Yes, ma'am. Okay, ma'am.
Do we have to do one more question or should we proceed further? Let's take one more example. Let's say one lesion removed without imaging guidance. Let me mention it here. So I have shared this question over the WhatsApp chat also. So these are our codes. Refer these codes, refer the guideline and tell me the correct answer. It's 353. You have to respond by 355. 59 needs to be used with the primary code, not with the add-on code. Okay, receive answer from two persons. Shilpa, any answer from your end?
And for the first one, it will be 10021 without guidance.
Hmm. Next one for three lesions.
I think it will be 10011 maybe. 10011, comma 59 it will be.
10001. How you have identified that this should be 10011? I don't think we have a code. It does not have a 10011. I mean, you are saying 10001, right?
Ma'am, it's before 10012, it's 10011. MR guidance.
Okay. Now let's do this question together. So you are correct on the first page that for first lesion we are going to use 10021 because this is without imaging guidance. Next three reasons has been removed under the MRI. So for MRI we have this one 10011. So we are going to use one primary and rest units we are going to build with the add-on code. You have to remember one thing, add-on code will always go at the second position, and with the add-on code we have to use a particular primary code. Okay, so 10021, no, it's 10012. So as three lesions has been removed under the MRI, so we are going to use 2 here and modify 59 with the 1 because this is our primary code. And for fluoroscopy we are going to use 10007, 10007 and 10008, as well as we are going to use the modifier 59 with this. So I think Prerna responded correctly. 21, 59, 2, 8. Very good, Prerna. And Zamir also responded correctly. Good. So now let's proceed with the next topic. So just one more time, our FNA codes are based on the lesions as well as the imaging guidance. Whenever a different imaging guidance has been used to treat the different lesion, we are going to use the modifier 59 with the primary code. Next, we have the previous FNA sections we have under the general section. And now we have a procedure performed on the skin, subcutaneous, and the accessory structures. That is corely integumentary system. In our integumentary system, first section we have introduction and removal. In the introduction and removal, we have the codes from series 10030 to 10036. In this section, we are going to build a procedure where doctor need to aspirate something from the patient's body or introduce means infuse something in the patient's body through the subcutaneous area. So aspiration means when doctor needs to evacuate the fluid from particular area with the catheter, with the syringe. So when the doctor is removing the fluid, evacuating the fluid, draining the fluid, that is known as the aspiration. And the introduction means whenever doctor is inserting something in the patient's body, that is an introduction. So our first code is 10030. That is image guided fluid collection drainage by catheter. Examples are abscess, hematoma, seroma, lymphocytes. And this code is based on the location. So whenever doctor is inserting the catheter under the image guidance to remove the fluid from the abscess, abscess means pus collections, hematoma, blood collection, accumulation, lymphocyte cyst and seroma from the seroma. Then we are going to use 10030. So 10030 is just for the insertion of drainage catheter under the imaging guidance. Next section we have soft tissue marker placement under the imaging guidance. Our code is 10035 and 10036. 10035 we need to use when the placement of soft tissue localization device has been inserted, such as wire, needle, radioactive seeds through the percutaneous approach. Percutaneous approach means through skin. Cutaneous means skin. Percutaneous means through skin under the imaging guidance. So when we have to do this soft tissue localization device, when we have to insert that, whenever doctor is doing planning any procedure or any biopsy, so before biopsy, doctor need to mark that area. So for marking, doctor may use the needles, may use the wires or even the radioactive seeds so that under the imaging guidance he can identify where the tissue from where the tissue has been need to be removed. So whenever doctor is doing any placing any localization device means that particular device which helps the doctor to localize the affected area. Then we are going to use 10035 for the first lesion. This code already included the imaging guidance, hence we are not going to build the imaging guidance separately with this code because this already includes that. And for each additional lesion, we are going to use 10036. It's same as an FNA. Next section we have incision and drainage. The difference between evacuation or aspiration and the incision and drainage means in the incision and drainage, doctor need to incise that area. Doctor need to make a cut there, then need to remove the fluid from that area. So in the incision and drainage, we have a codes from series 10040 to 10180. So in this incision and drainage, doctor need to incise that area first. Let's say if the patient have the abscess. So pus accumulation is there and there is a covering above the pus accumulation. So doctor need to remove that pus from that area. So what doctor needs to do? First, doctor need to create the incision, then accumulation of the pus, drainage of the pus. Then he is going to repair that area with a closure, simple closure, or he's just going to use the band-aid based on the depth of the abscess. So in the incision and drainage, doctor need to use the surgical instrument any surgical incisor to cut that area so that he can. Hello, hello, Jamil, you are saying something?
No, ma'am.
Okay, I thought so. Incision and drainage is just incising that area and removing the fluid from that area. So our first code is 10040, act surgery. Okay, 10040, that is act surgery, where doctor need to do the procedures on the act, and the examples are just opening or removal of the mila, cyst removals, pustules removals. So this comes under the act surgery. Next code we have 10060, incision and drainage of the abscess, cyst, hematoma, parenchyma, that is in the nails. So if when the doctor is removing the pus from the abscess, then we are going to use the 10060 when it is a simple or single. If it is a multiple abscess, we are going to use 10061. And the difference between simple and complicated means that complicated incision requires the drain placement. Doctor need to place the drainage device there so that pus will not accumulate there on that cavity. It will remove from the body at the same time. So whenever doctor is placing any drainage device there, then we are going to consider it as an complicated. If it is a one abscess and doctor is just draining that after the incision and allowing up for for the regular healing or the primary healing, then we are going to use the 10060. If it is in complicate, any drainage device has been used, then we are going to use the 10061. So instead of the drainage device, even though doctor is using any wound closure techniques also, so then in that case also we are going to consider it as uncomplicated. Any extensive packings are there. So doctor need to use WAC or something like that. In that case also we are going to consider it as in 10061. So the difference is whenever doctor is placing any drainage device, extensive packing like wound WAC, as well as uh, any subsequent wound closure required, then we are going to consider it as an complicated. Now we have these two codes. These two codes are specifically for the bilateral cyst, the cyst at the end of the sacrum. So basically, this is in sac under the skin at the base of the spine. So doctor need to cut, incise, and to allow the drainage and remove the epithelial lining by the curettage. So we are in that case we are going to use the 10080 for the simple one. When just doctor did the incision and allow the draining to be completed and just allowing for the open healing, and we are going to use 10081. Then there is any drain placement, any extensive packings, any secondary closure with the Z plasty procedure. Z plasty means any adjacent tissue transfer are required there. In that case we are going to use 10081. Now let's move to the one. You guys are aware that what is a pilonidal cyst, or you want me to describe it one more time? Now let's. So this is just a sac at the base of the spine. When let me show you. So this is the pilonidal cyst. So whenever patient develops a cyst here at the base of the spine, then we are going. Doctor need to just incise that area, and so that there should be the drainage, that accumulated pus or the accumulated area. Here you can see. that here we have the accumulated fluid or even the pus, so that it can be drained clearly through this sinus tract. So that will be 10080. And if doctor is placing any drainage device here, then we are going to use the 10081. Next we have 10120, that is incision and removal of the foreign body, subcutaneous tissue. So as its names, doctor just need to do the incision and just need to remove the foreign body from the subcutaneous tissue. The difference is simple and subcutaneous complex. So here we have doctor is not doing any drainage. So that is definitely not based on the drainage device here. The difference between simple and complicated is just if the foreign body is embedded deeply in the subcutaneous tissue, where doctor need to dissect the underlying tissues also. In that case, we are going to use 10120. So again, for simple, that is superficial. Let's change this word to the superficial. And for complicated, deep in the subcutaneous tissue. Deep in the subcutaneous tissue, when doctor need to dissect the underlying tissues also. In that case, we are going to use 10121. Next, we have 10140, incision and drainage of hematoma, seroma, and the fluid collection. Here we have the puncture aspiration. Okay. Now you guys need to tell me what is the difference between the incision and drainage and the puncture aspiration. What is aspiration means? Any answers? What is aspiration means? It's a simple word, aspiration. Aspiration means when the doctor is removing the fluid without incision, with just a puncture, like with just an syringe, then we are going to call it as an aspiration. But if the doctor need to do the incision to remove the fluid, we are going to call it as an incision. Let me see if we can find any particular question in regards to this. So we have one question over here. Question number 30. Well, okay. Now, in this case, if for the puncture aspiration, if doctor need the imaging guidance in conjunction with the puncture aspiration procedure, we are going to build the imaging guidance separately from series 76942, 77022, and this. So this will represent ultrasound guidance, this will represent fluoroscopy guidance, this will represent CT guidance, and this code will represent the MRI guidance. If the guidance is required for the puncture aspiration of the abscess, then we are going to use 10060. And next we have 10180, that is incision and drainage for the complex post-operative infection. So if after the procedure, patient developed the infection there, and doctor need to do the incision and drainage for that area, so we are going to use 10180. So in here we does not have a simple code, because for the infected wound, doctor need to reopen that area, removal of any suture material, doctor need to remove that, and then wound need to be drained, necrotic tissues, any dead tissues needs to be removed from that area. We have to irrigate that area with the normal saline, then we have to resuture them and pack the site with the particular gauze or particular sutures also. So that is already a complex, because for the redo procedures for the infection area, doctor need to do the debridement in conjunction with the incision and drainage also. Doctor need to clean that area also too. Any questions so far in the incision and drainage section?
No, ma'am.
Perfect. Now let's try to attempt the question number 12. try to solve the question number 12 and let me know if you have any doubts. It's 4:15. We will try to solve it by 4:17. It's 4:17. Any answers? Any answers, guys? Okay, let's do this question. Uh-huh. Yes,
Option B,
Jamil.
ma'am.
Option B.
Option B, ma'am.
Perfect. Now
Ma'am,
let's do this
option
question.
C.
Very good, Prerna. And Jamil, very good for attempting that too. Any other answers? Okay. So now let's do this question together. Patient had the abscess at her vulva, which is already burst, already burst. And now patient developed the soft tissue infection there as well as gas gangrene there. So doctor need to do the debridement here. We have to highlight that what doctor did. Doctor did the debridement of the necrotic tissue and then he removed all the pus, irrigated that area with the saline. Irrigation means doctor clean that area, wash that area with the saline, normal saline. And that infected area was completely drained and the wound was packed gently in the sterile saline gauze. And the pads were placed on the top of the wound. So I am going to rule out 56405 directly because this procedure is at the skin level, not at the vulva level or the genitourinary area. So whenever there is a procedure at the skin level, we are going to use the code from series 1 only. Now, why we cannot use 10061? Because Doctor is not doing any incision and drainage here. Doctor is doing the debridement here. Jamil, look at the question again. The doctor is performing the debridement, not the incision and drainage. Debridement means doctor is clearing that area. Abscess is already bursted there. We does not have any wall which needs to be incised to remove the drain pus. It has been already burst and pus is already here and there, and due to that gas gangrene only we are going to clean that area. So we are not allowed to use B's code because it will not align with our procedure. Doctor did the debridement, but the 10061 is for the incision and drainage. Doctor is not doing any incision. In the whole documentation, we does not have any documentation which says the doctor make the incision on the abscess. So we are not going to use this code. Now we are left with option C and D. Let's see the difference between C and D. So 1004, this is for the debridement of the skin, correct, which matches with our procedure. Skin, subcutaneous, muscle, fascia, and necrotizing soft tissue, that is on external genitalia and the perineum. Vulva area is in perineum area. And next, this is for the necrotizing soft tissue infection. Patient have the necrotizing soft tissue infection here. Look, soft tissue infection and the gas gangrene is a necrotizing area. So till now, our C answers matches with our procedure. Next, we have option D, 10042. 10042 we need to use when there is a debridement of the subcutaneous tissue without mentioning the disease. So 11042 is for the debridement without mentioning the disease. So we are not going to use the 11042 because in our case it was clearly mentioned that patient has the necrotizing soft tissue disorder. Clear? Everyone is clear that why the answer is should be C instead of any other. Zamil, are you clear that why the answer should be C instead of the B?
Yes, ma'am.
Now let's proceed with the next section of our chapter. Our next section is debridement. So debridement is a process of removing the dead tissues. So it's a process of cleaning that area. Okay. In that area, in the debridement, what doctor did, doctor just removed the dead tissues, any necrotizing tissue, any infected tissue, any dirt, any foreign material from that area, from the debris area or from the infected skin. So doctor just need to remove all the area with the particular tools. He may use curate, he may use scalpel, he may use sharp tools to remove that area. So that why we need to do the debridement, because it will promote healing. It will promote fast healing even, because if there is a dead tissue, it will not promote the healing. It will just create the condition much worse. So to promote healing and to control the infection also, we have to do the debridement. So debridement can be happen with a scissor, scalpel, or any sharp tool. So for the debridement, our codes are 10042 to 10047. We have few code based on the anatomical location, and for rest our codes are based on the depth of the debridement. Depth of the debridement means, so let's say our code starts from here. So our first code is debridement of the extensive eczematous and the infected skin. So this code is and this code. These two codes of for debridement are based on the type of condition. This one we can use when there is an infected skin, and this one we can use for the necrotizing soft tissue infection. So these two codes are corely based on the depth of the based on the disease of the skin. These two codes are based on this one is based on the total body surface area if it is in 10% and the more than 10%. Then we have the 1004 and 5 based on the location of the debridement. Now our core code starts from 10042. So 10042, 43 and the 46 are based on the depth of the debridement. So let's say the patient does not have any infectious condition. The patient just have the ulcer, maybe venous status ulcer, arterial status ulcer, any type of ulcer, pressure ulcer, non-pressure ulcer. So doctor need to clear that ulcer and need to do the debridement so that ulcer can heal fastly, or need to prep that area so that he can proceed with any skin substitute grafts also. So whenever doctor need to do the debridement for the non-infectious condition, we are going to use a code from 142, 042, 43 and 46. These codes are based on the depth of the debridement. Depth of the debridement, not depth of the condition. So let's say, let me pull one example here. Just a second. Let's see if we have the example here. So you can see here, patient had the wound debridement on the right lateral foot. Uh, Let me show you the image of the right lateral foot also. So this is our right lateral foot. Patient have total wound surface area is 52.29 centimeters square after the debridement. And this is our wound. So the code for the debridement is not based on the wound. That is based on the depth of the debridement. Depth of the debridement means you can see here in our documentation, doctor did the debridement till the muscle tissue. So doctor removed all the devitalized and non-viable tissue till the muscle tissue. So to decide the depth of the debridement, you have to proceed or you have to read out the complete documentation to understand the depth of the debridement. As you can see here, our wound codes are based on the size. In the same way, we have a code based on the size. So these codes are not based on the anatomical location. These codes are based on the depth and size. These codes are depth and size. So let's say if the doctor did the debridement for the subcutaneous tissue or 25 centimeter square. Doctor did the debridement of the subcutaneous tissue 25 centimeter square. In that case, we are going to use 10042, 10042 and 10045. Why we are going to use the 10045? Because 10042 states first 20 square centimeter. So if the 25 centimeter has been debrided, so for rest 5 square centimeter, we are going to use 11045. Why? Because this one is for each additional 20 square centimeter or part thereof. Or part thereof means like complete 20 square centimeter has not been removed, but just a part of that area has been removed only. So in that case, we are going to use the add-on code here. So this is an add-on. That means we cannot use this code separately. Next, we have 10043, muscle and fascia. So whenever the treatment has been completed till the level of muscle, we are going to use 43. If we have debridement till the level of bone, we are going to use 11104. For bone, we have one more code here. This one. We have to use this code only if the debridement is going to perform for the fracture or the dislocation and to remove the foreign material. So if the fracture has been, debridement has been performed to remove the foreign material, to clean that open fracture area or to clear the open dislocation, then we are going to use 110 And one more concept we have to follow here. As I already told you that our code is not based on the site, that codes are based on the depth and the size. So let's say patient have the multiple wounds. One wound at this area, anterior chest. This is till the level of subcutaneous. And let's say one abdomen wound. This one till the level of muscle. And we have one more here till the level of bone. So whenever patient have the multiple wounds, so the depth, we are going to build the size of the different depth wounds separately. We are not going to add the size of these wounds. So let's say 25 square centimeter, 32 square centimeter, and 40 square centimeter. So we are not going to add the size of these three wounds because the depth of the debridement of these three wounds are different. But if patient have the same depth wounds, let's say this one is a subcutaneous and here also doctor need to do the subcutaneous. But here doctor did 15 square centimeter and here we have 32 square centimeter. So whenever we have a debridement for the same depth, we are going to add the size of the debridement. So we have to add the size for the same depth, add the size for same depth, and we should not add the size when the depth of the debridement are the different. Clear? Okay. Are you guys able to follow? Any doubts, any questions? Let's take one example. Where is the paper? Just have the one question here for a debridement. This one excision, shape biopsy. Okay. Try to solve the question number 11. It's 435. Try to solve this question by 437. Any answers? I have received one answer. C. Any other answer except, okay, Prerna responded. Now let's take this question together. No, not on mute. No. So, patient is coming for the debridement. The debridement is performed on the infected ulcer. So remember, whenever there is an infection, we have to use a specific infection code as well as this chart. Using the sharp dissection, ulcer and the scar infection has been debrided all the way down to the bone. The bone had to be minimally trimmed because of the sharp point at the end of the metatarsal. After the debridement, there was a minimal bleeding due to the poor circulation of the foot. Poor circulation. It seems that toes next to the ulcer may have some involvement and the culture were taken. This area was sterile, dressed, and the closed. We have first code 111 110 is for the infected skin, but in our case, patient had the ulcer. So we are going to rule out this code 11010. So 11010. The primary code is 1110. We have to use this when there is an open fracture or any open thing. But in our case, patient does not have any open fracture here. So we have to rule out this one too. Next question, next option we have 111 So 11044 till the level of bone, which includes epidermis, dermis, and subcutaneous muscle fascia and everything. So we are going to use 11044. So the correct answer should be C only. Clear? Any doubts? Just need to remember one thing, that whenever we have a different depth which has been debrided, in that case we are not going to add the size of the debridement. But if that the area of debridement or the depth of the debridement is same, we are going to combine the size of the debridement or the tissue. Let's take one more question here. I have sent one question. Try to attempt that. Try to solve this question. Any other answers? Okay. Now let's do this question together. We received response A and C. Okay. So in our case, patient skid out of the control on the highway road while riding his car and contaminated with the road debris on right hand, right leg. Physician debride the wound on the right hand till the muscle layer, 22 square centimeters. So for muscle, 22. So wound on the right leg debrided 12 centimeter, which including the bone. So for leg, it is till the level of bone. So we have to use muscle and bone. So for muscle, we have 11043, 11043 for muscle. But this one is for first 20 square centimeter. For rest 2 square centimeter, we have to use the add-on code. So for muscle 11043 and 46, 11043 for 20 square centimeter and 11046 for each additional 20 square centimeter, as 2 centimeter has been debrided extra. Where is our question? Oh, I have removed the question. Just a second. Okay. So for additional 2 square centimeter, we are going to use 11046. For the bone, we just have 12 square centimeter and we just have one code, that is 11044. So the answer should be C instead of the A. And someone told me that should be A. So the answers. Okay. Vaishnavi, is it clear that why the answer should be C instead of the A?
Yes, ma'am.
Okay. Now our debridement portion has been completed. Let's move further. Next section we have pairing and cutting. Now let's understand what the pairing and cutting is. So when the doctor is removing the hyperkeratic lesions such as corn or callus from the foot, then we are going to use a code for the pairing and cutting. In this, doctor uses sharp instrument to pair or cut the corn or callus from the patient's body. Doctor may use local anesthetic also. So in that case, we are going to use the pairing and cutting code. So we just have three codes here, 55, 56, and 57. Based on the lesion, if it is in more than 4 lesions, we are going to use 11057. Even if it is in 7 lesions, we are going to use 11057. We are not going to use the units here because this code is more than 4 lesions. Now I have one question. Now tell me, if the 9 lesions has been paired and cut, what should be our code for the 9 lesion? How many codes we need to use for 9 lesions? Any answers?
Ma'am, 2 codes, ma'am.
Any other answer? Thanks, Jamil, for responding. Any other answers for 9 lesions? How many codes we have to use for pairing and cutting? Okay.
No, ma'am,
So
only
here,
one code, ma'am.
exactly, here we have to use only one code.
Yeah,
Why?
only one code, last code, ma'am.
Perfect. So the answer should be 11057. Why? Because doctor is removing the 9 lesion, but our code description states more than 4 lesion. So whenever there is a more than 4 lesion, 5, 6, 7, 20, any lesions, if it is in more than 4, we are going to use 11057. Okay, now let's move to the next section of our manual, biopsy. FNA biopsy, core biopsy, and the normal biopsy. This is an excisional biopsy. Excisional biopsy. These are the different types of biopsy. So we have a different code for excisional biopsy based on the different depth. From this section, code 11102 to 11107. We are going to use these codes whenever there is a biopsy of the integumentary system. This is an excisional biopsy of the integumentary system. In the integumentary system, we have a 3 type of biopsies, except the FNA and core needle. These are the, I'm talking about the excisional biopsy, where the doctor needs to incise or excise a particular area with a particular tools. So first we have the incisional biopsy, then tangential biopsy, and then punch biopsy. In the tangential biopsy, doctor need to use the scalpel or any flexible blade where doctor did the partial thickness removal. Now, what is partial thickness? In the partial thickness, doctor removed the epidermis and the dermis of that area. So, when the doctor did the biopsy of the lesion till the partial thickness, till this dermis level, we are going to call it as an tangential biopsy with the scalpel. We will call it as an incisional if it is till the level of subcutaneous. When the scalpel has been removed and the subcutaneous, till the subcutaneous tissue depth has been removed, for the biopsy, we are going to consider it as an incisional. For the punch biopsy, doctor need to use this punch tool. This is a tool where the sample is till the level of subcutaneous. We are going to consider it as an punch. So doctor insert this over the lesion and just rotate it in a circular fashion and then remove it out. Once the tissue has been extracted, then it has been removed it out. So our codes are based on the type of the excisional biopsy and number of lesions. So you can see here, our first code is triple 102. This one is for tangential biopsy of the skin, and the tangential doctor may use shave, scope. These are the name of the tools, saucerize and the curate. These are the name of the tools only. So if the single lesion has been removed, we are going to use 11102. If for each separate lesion, we are going to use 11103. And like in a FNA, what we have to do, we have to use each primary code and then add-on codes. But in the biopsy, we are not going to do this in a same way. In the biopsies, we are going to use only one primary code. We are going to use only one primary code and add-on code for the other techniques. Let's say 2 lesions of the tangential biopsy, 2 lesions of the incisional, and 2 lesions of the punch. So in that case, what we are going to do? We are going to use primary code for the incisional biopsy, that is 1106, the primary code for the incisional biopsy, and 11107 for the each additional. And for tangential as well as for the punch biopsy, what we are going to do? We are going to use the add-on codes only. So in the FNA, we have to use primary code for each lesion, but in the biopsy, we are going to use only one primary code and add-on code for rest of the lesions. Does that make sense? Is it clear to everyone?
Yes, ma'am.
Yes, ma'am.
Now let's take an example. I'm going to repeat one more time just to make sure that you guys are able to understand. In the FNA, we have to use the separate primary code, but in the biopsy, we have to use one primary code and each additional add-on codes. We have to use one primary code. So we have few examples here. Let's say there are two tangential biopsy, one primary, one add-on. 3 punch, one primary, two add-on. So let's say 3 technique has been used: incisional, tangential biopsy, and punch. So we have to use only one primary code and rest add-on code. And with add-on code, you are not going to use the modifier 59. Like in the previous section in the FNA, we have to use the modifier 59 with the primary codes. But here, as we are not using the primary codes, so we are not going to use the 59 modifier with the add-on codes. And let's take one example. I'm going to send one question. I send the question over the WhatsApp chat. Try to solve the question. It's 456. Try to solve it by 458. One primary, and then for each additional lesion, we have to add the add-on code. And to decide the primary code, you have to use the most severe one. Any other answers? Any other answers? Okay, I'll see the answer from Rona and Dizam. Now let's review this question together. So, in our question, someone responded directly. So, patient came for the hospital for the discoloration of skin on the multiple areas of the body. Doctor examined the area, took the multiple skin biopsy, in that one punch biopsy and the two tangential biopsy. So for tangential biopsy is till the level of dermis. The depth of the tangential biopsy is dermis. I have already shown you here that in the tangential biopsy we have to remove the tissue till the level of dermis. whereas in the punch biopsy, tissue has been removed till the level of subcutaneous. So whenever we are going to decide the primary code, we have to use the most deepest one at the primary. So for the punch biopsy, as this is still the level of subcutaneous, we are going to use the primary code 11104. So we have ruled out 02 and 06. Now we are left with option A and C. So 11104 and one punch biopsy and the two punch nitric biopsy. In the F biopsy, we are going to use the add-on codes for the different modalities. In the FNA, we are allowed to use the different primaries, but here we have to use add-on code to represent the less deep biopsy. So the correct answer should be C instead of the A. We cannot use another primary code in conjunction with the other primary. So we have to use only one primary code and add-on code for rest of the biopsies. Clear? Clear to everyone? Zamil, Vaishnavi, Prerna, are you clear that why
Well,
the answer is C? So clear. Okay, let me repeat it one more time. Like earlier, we have learned that whenever doctor is doing the FNA, we have to use the different primary code for each imaging modality, right? But whenever we are going to build the biopsies, for the biopsy, we have to use the one primary code, one primary code, and for rest of the biopsy, we are going to use add-on code only. We cannot use the another primary code for the different technique. We are going to use the add-on code only. Does that make sense? Okay. Now let's take one more example. Let's say patient is coming for 2 incisional biopsy, 3 punch biopsy, and 1 congenital biopsy. What should be our codes? Refer your book. Tell me the codes for 2 incisional biopsies, 3 punch biopsies, and 1 congenital biopsy. It's 5-3. Try to solve it by 5-5. One minute left. Any answers? Okay. So as there are 2 incisional biopsies, 3 punch biopsy, and the 1 tangential biopsy, we are going to use only one primary code. So our primary code should be for incisional. Why? Because incisional is deepest biopsy. Very good, Samil. So, so incisional is in deepest biopsy. So for incisional, we are going to use primary 1006 as well as one add-on code too, because this one is for the single lesion. For each separate lesion with the incisional biopsy, we are going to use the add-on code. So 1000, or not 1000, it's 11107. Okay. So 1. Then for punch biopsy, we are going to use add-on code because for the biopsies, we cannot use the primary code together. So for to represent the 3 lesions, we are going to use 11105 only. So 11105 into 3. And for tangential, we are going to use 11103. I hope. Yes, the add-on code is 11103. So the correct answer should be 11106, 11107. And then for rest 2 modalities, we are going to use add-on code only. We cannot use different primary codes with the biopsies topic. Clear? Zamil, now correct your answer. Just review the answer and correct your answer. And tell me if you have any doubt or if any of you have any doubts. Any questions, any doubts? Prerna, Vaishnavi, Zamil, is it clear to you?
Yes, ma'am.
Yes, ma'am.
Perfect.
Yes, ma'am.
So now just send the correct answer over the group so that you have the answer in the written. Send me the correct answer. Today I'm going to send you few questions from the integumentary section. Try to attempt these questions by the next week. We will discuss this question and proceed with the further chapter. So in this session, we have completed till the code number 11107. From the next session, we will start from the removal of skin tag. So thanks everyone. Let's wrap up the session now. Thanks. Bye bye.
Thank you, ma'am.